right. Let's see if I can make this go forward. You've heard a ton already about, the potential risks of therapy with all these different therapies. And in essence, every single treatment decision we make ultimately comes down to this balancing of the potential risks and benefits. So I'm going to start by just sort of reviewing what we knew coming into recent years, and then I'll give an update on new findings that have come out in the last several years. In brief, I think almost all of us would agree that thiopurines increase the risk of lymphoma, non-melanoma skin cancer, and possibly other cancers. The anti-TNF therapy association with cancer is a little less clear, but may increase the risk of melanoma and other cancers, but the risk generally appears to be lower than that with thiopurines. And we have really limited data on all the other drugs that we tend to use for patients with IBD. So let's look at some of the data that led me to those conclusions. This is an updated meta-analysis published last year that looked at the relationship between thiopurines and lymphoma. And although the study was done separating out population-based studies and referral-based studies, I'm only showing you the population-based studies. And here you can see a pooled estimate that would suggest that those patients with IBD who are treated with thiopurines have approximately a 3-fold higher incidence of lymphoma. Obviously, we worry about lymphoma, but there are lots of other types of cancers that people can get. And this study out of the Netherlands really, I think, helped to clarify this issue that in general, anti-TNF therapy has very little association with new cancer onset. So here you can see over a period of roughly 13 years, among 56,000 patients with inflammatory bowel disease, over 4,500 were treated with anti-TNF therapy. And regardless of whether you look at those who received any dose of medication or even those who received 8 or more infusions, so typically that would be a little more than a year of therapy, we don't see an increased risk of cancer overall. Many of us really got concerned about this cancer issue when the reports of hepatosplenic T-cell lymphoma came out in Crohn's disease. I don't think that this is what we knew in the past. I don't think the literature has changed that much in recent years. In general, these are cancers that have tended to occur in young males, predominantly in people who've been treated with thiopurines, and many of them in the reported literature had treatment with anti-TNF therapy as well. When this report came out already over 5 years ago, only 1 out of the 28 cases that was reported here had been successfully treated, and this is part of why there's such concern over this, that the cancer is almost always fatal. Those are generally more concerning cancers, but what we probably see the most is non-melanoma skin cancer. There's clearly an increased incidence of non-melanoma skin cancer in immunosuppressed patients, whether we're giving them immunosuppression for their inflammatory bowel disease, or because they've received a solid organ transplant, or because they've got AIDS. And in general, the risk of non-melanoma skin cancer is proportional to the degree of immunosuppression. There is some older literature that would also suggest that for those patients who developed squamous cell cancers in the setting of immunosuppression, that they may be a bit more aggressive. In the world of inflammatory bowel disease, we can see here a summary of several studies examining the relationship between thiopurines with skin cancers. On the left, you see the data for non-melanoma skin cancer, where all 4 of these studies have shown elevated risks of non-melanoma skin cancer among patients treated with thiopurines. 3 of the 4 studies with relative risk estimates around 2. In contrast, on the right, you see 3 studies that looked at the incidence of melanoma, none of which found that thiopurines increased the risk of melanoma. You can contrast that with anti-TNF therapy, where 2 studies really did not see much of a risk of non-melanoma skin cancer. And here I'm going to cautiously say of a first non-melanoma skin cancer, and we'll come back to that later in the talk, in contrast to 2 studies shown here suggesting perhaps a small increased risk of melanoma in those patients treated with anti-TNF therapy. Millie's study showed about a 2-fold increased risk, and then the French study showed again about a 2-fold increased risk, although that was not statistically significant. All right, so that's where we were coming into this. I want to focus the rest of the talk on a few things that we've learned in the last few years, and I'm going to touch on the issue of combination versus monotherapy. I'm going to touch on what happens when we discontinue therapy, think for a brief period about whether we should be targeting our treatment strategies to patients' age and sex, and then close by asking the question, what do we do when the patient's already had a diagnosis of cancer? Surprisingly, there's really not much data on the controlled data on the risk of lymphoma with combination thiopurines and anti-TNF therapy. Here I've summarized the results of 2 studies, and I would ask you to really focus on the 2 rows in red at the bottom of the slide. If you look at the column SIR for standardized incidence ratio, which you can think of as a relative risk, it looks terrifying with a 10.2 and 6.6-fold increased risk. But if you look one column to the left, you'll see that those estimates were based on a combined total of 3 people getting lymphoma. So there's an enormous amount of uncertainty around the degree of risk here. What we have seen is that when you look at patients who are treated with combination of adalimumab plus an immunomodulator versus those who received adalimumab alone, it appears that it's actually the immunomodulator that results in the increased risk of cancer. So here we've summarized the data from these adalimumab clinical trials, and you can see that the addition of the immunomodulator resulted in roughly a 3-fold increased risk of cancer, whereas those patients who got adalimumab monotherapy had an incidence of cancer that was comparable to what would be expected in the general population. And again, that holds true if you look at the bottom of the slide, whether we were looking at non-melanoma skin cancer at the very bottom or all other malignancies excluding non-melanoma skin cancer. Again, it seems that it's the addition of the thiopurines to anti-TNF therapy that seems to increase the risk. The second point is what happens when we stop therapy. Many patients who are doing well on combination therapy, you might think about, well, maybe I could get rid of the immunomodulator and reduce their cancer risk and hopefully continue them in remission just on their anti-TNF therapy. We do have some data to help us think about whether that would help reduce some of the cancer risk. This is the same meta-analysis that I showed you at the very beginning of my talk. On the top are the same data I showed you. So this is the 3-fold increased risk of lymphoma in patients who were currently taking a thiopurine. On the bottom shows the pooled estimate of the risk of lymphoma in patients who had previously been treated with a thiopurine. So they're no longer on it. And what you can see is the pooled relative risk estimate is only 1.4 and not statistically significant, suggesting that once you discontinue a thiopurine, that risk of lymphoma over time goes back to or very close to baseline levels. In terms of non-melanoma skin cancer, I think the data are not quite as clear. This study from Nabil Khan suggested that you had some increasing risk of non-melanoma skin cancer the longer you were on treatment. This was a study done in the US veterans. Then if we look at data from France and the same US veterans, of people who had previously been treated with thiopurines, so those who had discontinued it, in France, it appeared that the risk of non-melanoma skin cancer largely persisted, whereas in the US veterans, again, that risk went back to baseline. So my guess is that probably the risk comes down somewhat. I'm not sure if it gets all the way back to baseline. Pulling all this together, we might ask whether we should be adjusting our treatment regimens based on the age and sex of our patients. I'm going to show you the rationale behind this, focusing really on the question of lymphoma, which is if we think that thiopurines in particular increase the risk of lymphoma in a relative risk fraction, meaning in a multiplicative fraction, as opposed to just adding on a fixed amount, that means that the absolute risk will be even greater the older you get, because the baseline incidence of lymphoma goes up as we get older, much like other cancers. And using that theory, we have mathematically modeled whether treatment with a thiopurine is beneficial according to your age. And so on the left is a very old study that I did in the era of thiopurine monotherapy, when we didn't have anything else really to offer people. And there you see on the y-axis is an estimated gain in quality-adjusted life years by using thiopurine therapy, and on the x-axis is the age of the patient. And what you can see is up till about age 60 or 65, in a world where all we had were thiopurines, the risks were outweighed by the benefits. On the right image, we redid this study asking whether adding a thiopurine onto anti-TNF therapy would have a similar relationship. And the figure is set up in the same way. The difference here is that each curve is a different age of patients at the time of starting the drug, and the y-axis is how long are you willing to keep people on the thiopurine. The take-home point is about the same though. Somewhere up around age 65 or 70, that increased risk of lymphoma may start to outweigh the benefit of combination therapy. All right, I'm going to close with just a few comments about what if patients already have been diagnosed with cancer? What should you do? This is a meta-analysis that looked at the difference in the rate of cancer recurrence in people with a history of cancer who were treated either with anti-TNF therapy or with an immunomodulator. And the point estimates on the left would suggest that there was a lower risk with anti-TNF as opposed to the immunomodulators. And you can see that the point estimate suggests a small beneficial effect of anti-TNF therapy relative to immunomodulators in terms of reducing the risk of recurrent cancer. The one problem with this meta-analysis, and I was one of the authors on it, but that's okay, is that it pulled together a lot of different cancers. And when you see your patient who has cancer, they've got some single type of cancer, and that's really what you're concerned about. So in the last year, we've published 2 studies that addressed single types of cancer. The first one looked at this issue of non-melanoma skin cancer. By far and away, this is the most common one that we see in our practice. People just came back. I've now had my second basal cell. What am I supposed to do? So we looked at Medicare and Medicaid beneficiaries who had a prior history of non-melanoma skin cancer and no documented recurrence for at least 1 year. The population included close to 7,000 patients with rheumatoid arthritis and just under 3,000 patients with inflammatory bowel disease. First of all, recurrence was relatively common, about 6% per year recurrence rate. But the important message is it almost didn't matter which immunosuppressant drug you gave them. It tended to slightly increase that risk of non-melanoma skin cancer. So at the top, you can see methotrexate with a relative risk of about 1.6 in patients with RA. And if you added anti-TNF on top of methotrexate, that was another 1.5 increase. And then you can see thiopurines, although not quite statistically significant, also with about a 1.5 relative risk. And although the anti-TNFs in the IBD patients weren't statistically significant, it was because of small sample size. Lastly, how about breast cancer? This is actually another one where you will see patients who've had a history of breast cancer and now they've got active disease again. So again, these are Medicare and Medicaid beneficiaries who were diagnosed and treated for their breast cancer and had no documented recurrence for at least 1 year. We matched these patients on their surgery type, whether they'd had radiation therapy and whether or not they'd had chemotherapy. And here we included patients who were treated with methotrexate, thiopurines, or anti-TNFs. And I've summarized the results in this figure. It's very easy to see. Methotrexate and anti-TNF did not appear to have any impact whatsoever on the risk of recurrent breast cancer. But thiopurines had about a 2-fold increased risk, albeit not quite statistically significant, largely because the much smaller sample size. All right, so what should you tell your patients? I think I still fall back on the fact that most of our medications work pretty well. They have some baggage that comes with them, but for most of these patients, the benefits outweigh the risks. I do think there's some value to considering avoiding thiopurines in the elderly and in young males when possible, although you have to personalize this. You can really think about those patients who are doing well on anti-TNF therapy plus a thiopurine for an extended period of time, potentially discontinuing the thiopurine, particularly if it's a population who's at high risk of cancer, such as the elderly. Most of our immunosuppressant therapies will increase the risk of a first and recurrent non-melanoma skin cancer, so the real key here is surveillance. If you catch these things when they're small, they're not very disfiguring. If you wait for them to get big, you get into trouble. And lastly, I will say, for those patients who had a prior solid cancer that is deemed to be cured, you probably can sort of use any therapy, but I tend to steer away from thiopurines in that setting for fear that I may increase their risk of recurrence. And my last slide, I think, applies to the fact that you've been sitting here for over an hour now, hearing all sorts of information about the risks and benefits and the potential hazards of these therapies. And at best, you've got 20 minutes in the office with a patient to try and help them understand all of this. This is a huge challenge, and efforts have been put forth by Corey Siegel and others to develop tools to help patients understand these issues, but I think it's really important that we take advantage of those and even continue to make new information tools for them. And so I thank you for your time and look forward to the discussion.